I can't sleep when I lay in bed. Too much thinking in my head. I don't know what to do anymore. But come on now, tell me the score. Is there anything I can do to get out of these tragic blues? I'm a victim of circumstance. I never really had a chance. I lay down and stare at my feet. You know the world has got me beat.
Hello and welcome to today's edition of Mental Health Matters. The title of our show today is The Things Your Health Insurance Does Not Want You to Know. And our guest for today is Laura Reich with Disability Rights California. And Laura is an attorney at Disability Rights California and is going to talk to us a little bit today about the complex topic of parity. Thank you so much for being with us.
Thank you for having me here.
And I say that it's complex because I have myself been trying to figure this out and help people figure this out for many, many years. So we appreciate you coming on and shedding some more light on it for us. Would you start by telling us a little bit about what mental health parity is?
Well, there are a couple of laws in place that require private health insurances to provide mental health services that is no more restrictive than providing physical health services. So we're looking at like co-pays. You can't have your primary care copay be $35 and your therapist copay be $50. You can't have out-of-pocket costs at the end of the year being much higher because it's more restrictive, and it's harder to it's harder on the consumer to get those mental health services, and that's what those laws are trying to combat. So
really, in terms of parity, is to make it on an equal footing with physical health in a lot of respects.
Right. Parity, the definition of parity out of the dictionary is that they are equal, but we are really looking at equal to the quality of the health care plan that you have.
Right. Because even with parity, it seems that there is still such a dearth of mental health services, even on the private side, or a lack of qualified people to deliver those services. I mean, you know, some organizations still seem to have a real hard time keeping up with that kind of capacity.
Right, and so you're looking also at network provider networks, timely access. Those are all still part of the parity requirements under the laws.
They are. Okay, great. So can you give us some examples of parity? I think you gave us a little bit.
I gave the financial type stuff, you know, the number of appointments that you can have in a year.
Right, they used to limit that severely.
Absolutely. They also used to severely limit the number of days a person can be in an inpatient facility, making it more difficult to see a doctor because of inadequate networks. Right. More strict utilization reviews where they are checking maybe weekly, sometimes every other day, to see if your services are still medically necessary as they define it.
Right.
So those are all parts of mental health parity.
So who determines and defines parity?
Well, that's a really good question. So there are, that's what I thought. So there are two basic laws. California has a mental health parity law, and that was actually put into effect in 2000. Yeah. So it's older, it's been around for a while, but the details on that one is not very clear as to what they're defining as parity. The laws, the paperwork went into making the law basically talks about mental health services need to be provided equally, but they didn't really define what that means.
How do you specify that? Right.
There's no details there. Right. The federal parity law is different. The federal parity law was enacted in 2008, but the final rules on how to implement it didn't come out until 2013. And the federal rules get very detailed into what they describe as parity. For financial requirements, they look at, under this whole aspect of copayments for your primary care and then your specialist care, they look at the predominant copay that is used for that range, and then mental health parity or mental health services can be no more restrictive than that one base amount. They also get into a lot of description about what they call non-quantitative treatment limits. And those are those treatment limits that have no financial or no number to it.
Right, like
That's
it's five services a year or 5 therapy appointments a year or something like that. So that would be eliminated.
That would be under the numeric stuff. Maybe the number of appointments you can have in a year, the number of the appointments within a year, or a limit on how many days in the hospital. But when you're looking at the non-quantitative, you're looking at something that has no real number value to it. Things like step therapy, where a person is required to try a lesser intense and very possibly a less effective treatment before they're allowed to try the treatment that their doctor wanted them to do.
Right.
Utilization review. Then there again, it's what they're looking at. Is it a prior authorization requirement for everything? Are they looking at any concurrent review? Is there a retroactive review? Those sorts of review requirements have to be the same for physical care also. In that sort of stuff. I actually haven't.
Yeah, so it sounds like the federal law has been a little bit more specific in terms of laying out those guidelines, although it took 5 years, it sounds like, to get that information published.
They have close to 2 pages of examples because they couldn't figure out how to word it right.
Well,
So
it gets really confusing.
It does.
Yeah.
So they've got all these examples as to try to give people an idea of what they're looking at when they're saying that it has to be an equal requirement or an equal setup.
So let me throw out an example because we get calls, from folks in the community that are struggling trying to access mental health services, and one of the ones I get a lot from the folks that are accessing on the private side. We generally help folks that are receiving services on the public mental health system, but oftentimes we will get calls for people that are receiving it in the private side as well. And so sometimes people say, well, I wanted to see a psychiatrist, but they sent me to a support group instead. Or rather than having a one-on-one appointment with either a psychiatrist or some kind of mental health clinician, they are kind of, for lack of a better word, forced. It sounds like somewhat forced into some kind of a group therapy thing, like a DBT or something like that. And I don't really know what to tell them because, maybe those things will be effective or not, but I don't know particularly what their rights are under the law. If they want an appointment with that doctor, I certainly think that they should be able to get an appointment with that doctor, but it doesn't really always happen that way.
Right, and that's part of the utilization review. They do it obviously they do it more strictly when we're looking at mental health. But when an insurance plan is actually taking the recommendation of the doctor and either modifying it, delaying it, or saying that they can't have it, denying it completely, then they are actually affecting or changing the orders of the doctor, and that is going to be actually evaluated under the parity law as to whether they are applying the same strategies, the same
as they would
network as they would under physical health.
But it really wouldn't have much to do with what the client wanted necessarily. So if the client wants to see the doctor and the doctor or whoever says, no, you can't, and you have to go to this class.
No, that's still an appealable issue.
It is.
It
Okay.
really depends.
Yeah.
Those are going to be based on the insurance plans, the insurance definition of medical necessity,
Right.
and what they think is an appropriate treatment. And all of that kind of insurance, all those issues can be appealed.
Okay, great. Well, that's really good to know. So where would somebody go to appeal that? Just to their plan provider?
Well, so yes,
I see you smiling.
that's a start.
Yeah.
So it really depends on who is regulating the plan and where the plan is
Right,
coming from. Each and every health plan is going to have some sort of internal appeal process. And you got to go through that one
Exhaust that
first.
first, I
You
see.
got to exhaust that. And it's really, those are really pretty easy. You either call and say, I don't think this is right, or you send
Right,
a
a
letter
little
saying,
letter,
I don't
yeah.
feel this is right. After that, then it gets a little more complicated. If the plan has one level of appeal and they deny you, they will send you a letter that tells you who regulates them. In California, if it is a California health plan,
Department of Insurance.
actually no. All the HMOs and then, oddly enough, Blue Cross and Blue Shield PPOs are regulated by Department of Managed Healthcare.
Okay.
The other plans, the PPOs
Their
and stuff,
I know.
that's
See, I know
the
there's some
Department of
confusion
Insurance.
there. I just wasn't sure
Right.
how it played out. Yeah.
So those are two separate entities. They are split. The Department of Insurance doesn't cover as many health plan, but they cover all of the others. It's
Right.
DMHC that has the majority of the people in California. However, if it's not a California purchased plan, as in it's not, the insurance company is not in
like
California,
specific to California. Or it doesn't even.
wasn't purchased in California, or it was, but it's an ERISA plan, which means that it's the employer has their own self-funded plan. They've got money put aside to do
Right,
the
right.
insurance coverage and stuff like that, and they've hired a management company. Anthem quite often
Right.
does utilization management, Kaiser, that sort of thing. If it's an ERISA plan, it's not regulated by California law, and so there isn't a different appeals process. If the plan is here in California, however, the main purchase is outside of California, those really big companies like
Right.
Target or Walmart or something like that, their main office is in a different
Yeah.
state, and they buy the base plan in that other state, then you're going to be doing the second level of appeals in that
To
state.
that state. Wow.
So it really will depend on
The
where
individual,
the
plan.
where the plan was purchased, what kind of plan was purchased. And all that information is going to be in their evidence of coverage under the grievance process.
Okay.
And that'll tell you what kind of plan it is and where to go after
So that's
the
what
next
people
step.
need to be looking for if they find themselves in
That
this kind of situation.
110,
Evidence of
120
coverage.
page booklet.
Yes,
That's
yes.
called the evidence of coverage, not the
Yeah.
summary of benefits.
Okay, yeah. I see that in my Western Health Advantage book. I don't know that I've ever really looked through it all, but
Yeah, you can flip through. It's generally in the back.
in
It'll
some
tell you where.
places carve out their mental health. Like they might carve it out. Say,
Right.
I think Western Health, which what I have, I'm just going to use them as an example. I think they carve it out to like Magellan or something like that.
Right.
It still applies though. It doesn't matter who is providing it. Right?
Absolutely. The subcontracted plans or the purchased plans through a a managed behavioral health
Right, right.
organization, they still have the same appeal process.
Okay.
So they're
you
going to
would go
have one
through them.
internally. They're going to have one internally through that, like Magellan.
Right.
Optum is another one. You go through their appeal process, and then it would then go to DMHC,
Right.
CDI, DMHC, or CDI is California Department of Insurance.
Okay.
I talk in acronyms.
I know we all do in mental health. It's awful, really. Yeah, so it's really kind of tricky for people in a way, even though, it's a great
Right.
protective law that has gone into place here. But knowing, that's why this is so important, having people know their rights and what kind of avenues they can take if they feel like their needs aren't being met or they're being violated in any way is really important information.
Absolutely.
And it's been a little bit hard to access that information, I think, for people,
It is, and people don't get the general information that their evidence of coverage is the one that the book
that they need to go from. Yeah.
Absolutely.
So is parity available to everyone?
Unfortunately, no. So let me break it down a little bit for you. The California parity law is for those plans like our grandfathered plans before the Affordable Care Act, small employer plans, those types of plans. And the California parity law is actually very restrictive. It only requires parity for 9 serious mental illnesses.
Yeah, I remember that.
That's, major depression, bipolar, schizophrenia, schizoaffective disorder, anorexia, bulimia, panic disorders, obsessive compulsive disorders, and autism,
Wow.
or pervasive developmental disorder.
So they don't even cover things like PTSD
They don't.
or anxiety. Well, I mean, it sounds like panic disorder, but only if it's gotten to that extreme.
And it depends on how that's defined. It's the DSM-5.
Right.
So you have to look through the DSM-5 and see which of your diagnoses falls under that panic disorder thing.
Wow.
So if your plan is covered by the California parity law and you're not within those 9, then the plan does not have to provide mental health services at parity. And
So they don't have to come under the federal law.
well, there is an
So
overlap.
I always thought federal law trumps the state law, but I don't know.
Well, so the California law is a mandate. It says if you're offering any sort of benefit, any sort of physical benefit, you have to provide mental health benefits at parity for this group.
Gotcha.
So it's a mandate, it's a required law. The federal law is not a mandate. It actually says if you provide mental health services, then it has to be provided at parity. So for those plans that's got the California requirements, that's not exempt from the federal parity law,
Right.
there is an overlay. So the federal parity law has, because it's not a mandate, that's how they try to limit the exposure and the costs for the insurance plans. But there is no limiting disability. So it is available for any
Right,
mental health
right.
disability
That's what I was
and
wondering.
substance use
Yeah, and
disorder,
substance use.
unlike the California law.
Yeah.
But they have their own ways of trying to limit the exposure for the insurance plans. They do allow some limits. It doesn't have to provide coverage for everything at all cost.
Right.
But back to the
These
California
insurance
plan,
companies must have a lot of lawyers working for them.
They've got to. They've got.
I
to.
don't know how else they could figure all of it out and find out ways that they could minimize their risk. And
Absolutely.
Yeah.
Well, and there are some health plans that don't apply to either of these parity laws.
Really?
Medicare does not fall under either the state or the federal, and unfortunately, Medi-Cal doesn't either.
Wow.
Veterans benefits don't fall under either of them either.
Boy, that's really where we need some parity,
Absolutely. And then for, as I had mentioned earlier, those self-funded plans where the employer has that money set aside and has
Right,
hired
right.
just a
Like the
management
ERISA.
company, they are not subject to the California parity law. And because they're not subject to the California parity law, here's where it gets convoluted and confusing.
Again.
Because they're not part of California law, there's no mandate. So unless they provide something, the federal law will not apply.
So it's almost better for some of those employers to not provide anything.
If they're an ERISA plan and they choose not to provide any, they don't have to.
And that would be for mental health only.
For mental
Right,
health
right.
services, mental health and substance
Yeah.
use
So
disorder.
they could provide, say, medical services or medical insurance, but they don't necessarily have to provide the mental health, and then they wouldn't come under this
Right,
this law. Wow.
absolutely.
Now, under the ACA, I know that there's all kinds. I don't want to confuse
Oh
us.
no, let's throw in another
Yeah,
law.
let's just
You
throw in
gotta do
another
it.
acronym, the Affordable Care Act. It's expanded coverage for a lot of people.
It has.
And as a result, you would think that more people would be eligible, and then also more people would be eligible for mental health services. But I don't know how that meets up with the.
Thank you for playing into that one. The nice thing about the Affordable Care Act is, as you said, it expanded coverage. And those essential health benefits? Well, number 4 or 5 in there is mental health services. That has now created a mandate. So all of those individual all those small group plans
Right, I was
that are
mentioning that. They have
based
to.
on the Affordable Care, on the expansion of
Right.
the Affordable Care Act. You know, those plans that are on the exchange,
Yes.
and the individual plans that are based off of those exchange plans that fall within that same sort of thing. They are all subject to that federal parity law.
Well, that's
because the
important.
because of the essential
Yeah,
health benefit.
Right. Well, that makes me feel a little bit better because you hate to see people getting out of this coverage, you know, for
Absolutely.
providing this coverage for their employees and things like that when it's just so critical. And it really is part of a whole health care system. You know, you can't just
Right.
remove mental health from that and only provide medical and physical health benefits. You're leaving out an entire component of people's health.
Absolutely.
And so that, you know, we'd hate to see that. So I think we talked a little bit about it, but who would not be covered under parity law? And
Well,
so it sounded like Medicare.
I hit the groups. Medicare, there has been some research. So your Medicare A and B, you know, your hospital and your doctor plan, is not going to be covered by either parity law.
Either one.
That gap coverage, the Medicare C, it's going to depend on where you purchase it and how you purchase it as to whether it's going to be covered by parity laws. Especially since I have now seen a lot of advertisements where you can buy your gap coverage, but the plan is outside of California.
Outside of California.
So it's really got to be, you got to be careful as to where you buy that. Sadly enough, the federal health plan, federal employee health benefit plans, they are not subject to either parity law.
Right. Wow.
So all your federal employees are not subject to
Really?
them if they've gotten their employer purchased
Wow.
plans.
It's a little hypocritical.
They have their own parity requirements. It's not as
So it's not like they don't
extensive.
have any. Yeah.
Yeah, they've got some. And you know, when they put out a bid to the plans, they've put in some requirements, but it's more of a suggestion
Right.
than a mandate or a requirement.
So, and it doesn't apply to veterans, huh?
It does not apply to veterans.
That's really
Not the veteran affair
concerning as
plans or the
well.
TRICARE plans. where the
Right, because
families are
we
covered.
often get calls from people who are veterans who are struggling with some kind of mental health challenge, and where to link them, we generally will send them back to the VA or,
Right.
you know, and I have been developing more and more mental health programs through the Veterans Administration, but it's still pretty inadequate in a lot of respects, and so where do those poor folks go? And sometimes you can get them on public, you know, mental health services, but even at that, it doesn't sound like the parity laws apply.
The parity laws won't
And
apply to that.
oftentimes in those plans, PTSD or things like that are not considered target population. I mean, some of the counties and I think the state are looking at that a little bit more now and trying to expand that, but that's been a problem for many, many years.
Right. And, you know, with this, as convoluted as all of these laws have been and where they're going to, I haven't had the Veterans Affairs stuff is definitely an area that I want to start researching.
Right.
Their laws are really hard to get into to see where they've got their health coverage, their mental health coverage.
Right. And what kind of things that they're really, you know, eligible
What
for.
they're supposed to cover
Yeah,
versus what
and
they
it's
do
just
cover.
become such a critical issue, and you want to be able to make sure that people get linked with services, particularly when they're seeking, you know, they're actively seeking services and need some kind of support, and that can be really, really difficult for those folks to navigate. As you know, this stuff is so confusing to everybody. I mean, I feel like they need to do a better job educating the public.
Absolutely.
I mean, obviously that's why we have you here today.
That's
Yeah.
why I'm doing this work
Yeah.
as I am right now. You know, I've gotten a small grant through the Cal Mesa project and Prop 63 funds to help educate people about their rights.
Right.
And you know, there's a wealth of information online. It's just really hard to figure out what you're reading.
Yeah, I mean, you kind of grab pieces from here, there, and everywhere, but to try to condense it down into,
Right.
you know, and particularly for somebody who may be experiencing some kind of emotional or psychiatric distress while they're trying to figure out how am I covered, you know, what applies
Right.
to me. That's so difficult, you know, and
Right.
yeah, and it doesn't seem like we have, you know, any particular sort of clearinghouse or place for folks to begin to find that.
Right. I mean,
that would be really great if we had something like that. Can you write a great grant for that, Laura?
There you go, sure. I mean, if you know what kind of health plan you've got and who the regulating agency is, and
You
it's
should be able to
definitely
follow those.
DMHC or CDI, if you have that information before there's an urgent need for it,
That's the idea.
that way you know who to call. Actually, both CDI and DMHC have help desks to help people argue with
Oh,
their
really?
insurance
Okay,
plans
great.
about denial of coverage and stuff. And if it's an urgent situation, the response coming back has to be as urgent as the situation that you're in. It can be as short as 40
So
hours.
basically,
to
they
find
can't
something.
just ignore you if you know your rights and if you follow through and you follow those steps.
And
yeah.
I know that both help desks have been very helpful and very kind to people on the phone in helping them work
Good,
through their
good.
problems.
Well, that's really helpful. We'll make sure we can maybe put some of that information at a future show or somehow
Right.
get it out to the community, because I think that's really important. Even what you're explaining about knowing your summary of
I mean, if you know who you can appeal to.
yeah, you need to
That's-
know
you
that.
gotta
But I
know
think,
that.
sometimes I've been in these situations where you kind of get so tired sometimes and you think, I'm just tired of fighting. I don't want to make another phone call. I don't want to deal with this. And obviously, we kind of have to if we're in that situation, but it's just unfortunate. Does it really have to be this hard?
I know.
The whole idea of providing mental health services should not make you sicker as you're trying to navigate it all. So we talked a little bit about, sort of which laws apply to which.
Right.
Is there anything you wanted to kind of to add in terms of that? I know that part gets a little bit complicated as well, but
I think, well, I suppose I could get more convoluted in detail about these laws. Really, what we're looking at is for like the California law, it's all medically necessary treatment for those 9 disabilities.
Right.
Now, they have just tried to limit it to the statute. It says, maximum lifetime benefits, co-payments, deductibles, but we had the best decision ever in 2014 called Ray v. Blue Shield of California. And that's when the judge sat down, looked at this case. What the case was a woman with an eating disorder had wanted residential treatment. And the insurance company said, per the California law, we don't have to cover it because it's not a financial limitation. We're not discriminating against, we don't provide this kind of service under physical health, we don't have to provide it under mental health. And the judge in the appellate court, best quote ever, it's not a one-to-one, I'm not quoting him directly, it's not a one-to-one matching, it's the quality of care.
exactly.
So the California mental health parity law is that you have to provide all medically necessary treatment to achieve the same quality of care as the physical health care.
Right. So if it's something she really needed,
Right.
you have to apply. You have to provide it.
Right.
Yeah.
So we've got, that's a great decision.
Yeah, that was a
and
great precedent.
That's for an HMO.
And that was just in 2014.
That was in 2014.
So that strengthens some of this.
That does. It was a great decision that came out.
Yeah, absolutely.
Posted on our website, giving everybody the information that they can.
That's great to know.
So, that's where your limits are, and that's where your requirements are for the state law. The federal parity law is looking more at a balancing of if you provide a service under, they've got 6 classifications. It's inpatient, in-network, inpatient, out-of-network, outpatient, in-network, outpatient, out-of-network, emergency care, and prescription drugs. So what they're balancing is if you provide any kind of treatment in any one of those 6, you have to provide mental health services in all of those 6. And you're balancing, your comparison is within each category. So we're not trying to compare residential treatment with going to see your primary care doctor. That it's primary care and therapy and stuff is going to be, your outpatient in-network doctor. That balancing has to be done in that group. Your prescription drugs have to be done in that group. A health plan is not going to be allowed to do, one medication that, on the formulary, one medication that's really cheap, not necessarily effective, for a specific type of illness or disability, and yet provide for mental health, and yet provide 15 for physical care.
Right, right.
So there's a balancing
So
within
that whole
each of
limiting,
them.
yes.
Right.
Yes. Yeah.
So
trying to sometimes they'll try to get the cheapest medicine, or kind of
or they restrict you, as in you have to try this really cheap medicine
before
first.
you get to there.
Yeah,
yes.
that's step therapy,
Right.
and
That
that's
happens.
very
Yeah.
popular. That's very popular. But that's where that balancing is. It's within like treatments.
Like treatments.
And then the plans have to decide which treatment goes into which group. But they have to categorize all of them. There's no, it doesn't fit here and it doesn't fit here, so we'll not fit it into anything.
Right, right.
It has to fit into a pocket. And then the balancing goes within the pocket.
Well, that makes sense. It sounds
does.
more fair to do it that way.
It does.
Yeah.
It's a whole lot more guided. It really does provide a whole lot more information to the plans
Right, right.
and to the consumer, so they know what they're looking at.
Right, so they understand. It's a little more tangible also. What about timely access to services? I mean, I would assume that is also can be a parity issue.
It is. I mean, especially when you're looking at network of providers. The federal parity law really does get into that. That's
Really?
another one of those non-quantitative treatment limitations. Is there an adequate network to provide appropriate services?
Right.
California actually has specific timelines.
Really? Really?
If you call for an appointment with your medical doctor, your primary
Right.
care, from the date of your call to the first available is like 10 days. Same for a therapist.
Really? Well, that's nice.
It is the same limitation. Those requirements have come out fairly recently.
Really?
Specialty care is 15 days.
That's
But
what,
your
that was
primary
my
care
next,
is 10.
Yeah, my next question.
But the definition of specialty is
Right, and
is
some
a
people
different one.
look at the mental health as a specialty service on some plans, right?
Right. But they want to call them specialty, but the laws in the state is really not for your therapy or based counseling. They're not getting away with that.
Right,
They're being
okay,
required.
good.
It's 10 days.
Yeah. That really, I think, helps people.
It
Yeah.
does.
Absolutely. What are some of the agencies out there that can help? And I think you mentioned a couple.
There are. I know that Disability Rights California,
Right.
we've got we've got a group of people in our agency. We have worked with pretty closely with Mental Health Advocacy Project, Mental Health Advocacy Services, Inc. down in LA.
Right.
And DMHC and CDI are both very willing to help talk people through things. We've been trying to get the word out. Each Mind Matters has got a website now that has got all sorts of publications about information, who can help, what kind of things they can help with, what people's rights are. There are a couple of toolkits available, one for state law and one for federal law, so that people can get help with the process of how to appeal. And the materials in there are to help them figure out where they're going and what to do with it.
It's a lot to figure out
There is a lot.
when
to
you're not an
figure out.
attorney. And even,
It's a lot to figure out,
I was
even if
gonna
you
say,
are an
even if you
attorney.
are, there's just a lot of different layers to it, it seems like.
Right.
And in terms of sort of any of the trends that you see happening, or are you seeing that there are people that are struggling in one particular area of accessing mental health services than others, or where this parity issue is sort of rearing its head? Or
I'm seeing a couple of areas. The big one that I've seen most of all has been a lack of an appropriate network. Has been, and not being able to receive services. the sad thing
within your
is,
community. Yeah.
within your community. Unfortunately, I think the most recent statistic I had read is about only 53% of mental health providers accept insurance.
It's true.
So
it's true. We see this a lot.
to be able to get into a provider who accepts a plan is difficult. And the plans are required to find a way of either pulling people into their network or finding some way of covering those mental health services appropriately.
Yeah, very interesting. I know that you mentioned that it doesn't really apply to Medi-Cal or Medicaid or Medicare.
Right.
And yet, what does apply there? Because what you see sometimes, and this is actually, and not intended to be an indictment of rural communities, but we see it a lot in California in the rural communities where they don't even have a psychiatrist or a mental health professional in that community. And so those people really, really suffer. And sometimes there's attempts to provide some kind of creative solutions, whether it's through telemedicine or this and that. But there's more than a few in California that do not have adequate mental health services on the public side, let alone the private side. In these very same communities that aren't providing it on the public side, they don't really have any providers providing it on the private either.
Right. I know for at least Medicare, they have their own parity requirements, but they've had them for so long, it's never been a parity issue itself.
It's kind of embedded in there, yeah.
Right. For Medi-Cal itself, as I said, Medi-Cal isn't subject to these parity laws themselves specifically, but with the expansion of the Affordable Care Act,
that's what I was wondering.
you've got the managed care plans. I have seen fairly recently a notice that the federal government has gotten some guidelines, some final rules for that expansion that's based upon the Affordable Care Act. And those guidelines are supposed to be coming out sometime this year.
Really? That would be helpful.
That will help with that. Telemedicine is also a non-quantitative treatment limit. Any sort of, or in my mind it is. If you can get telemedicine services for diabetes control or that sort of stuff, then it has to be available for mental health services too.
Well, typically what's sort of happening, or what we see happening, is that it isn't really being used for the public health side because they have their doctors and things like that to do that, but it is being used for the mental health side.
Right.
Because it's really difficult to get psychiatrists in some of these communities.
Absolutely.
And I have my own opinions about it not being a priority that it should be to some of our, the policymakers and the leadership. Because I think if there's a will, there's a way, but it's just very hard for us to tell people when they come to us and say, they don't even have a psychiatrist for me to see, and I have a severe mental illness, and I've been struggling, and I need some help and support. They have transportation issues. Where are they supposed to go?
Well, for the private plans, I'm not going to give names or anything. I have seen some evidence of coverage booklets that say, if you need these services.
I've seen the private plans actually
and
outsource
you
it.
Can't get an in-network provider, we just don't have somebody who does that, then they can do a single source contract where they will pay that out-of-network doctor, somebody who's not even part of a health plan, what they would be paying their in-network doctors. It doesn't necessarily mean that they're getting what the doctor's been asking for.
Right. And so that could be another barrier for folks as well, because perhaps the doctor won't accept that.
And the federal government actually has that in part of their descriptions of a non-quantitative treatment limit.
How do we get parity on the public side? I know it's been honestly, since I've been working in the field, it feels like parity's always been on the horizon, or we've passed these bills that weren't really that substantial.
I really don't know. I know that we've been, as I said, we're looking at the Medi-Cal expansion. That's a start.
Yeah, I agree.
As people are understanding that they have these rights, and that there is no stigma to getting what you need, people are going to start demanding the things that they need. And unfortunately, it's that whole
Understand
economic
that.
supply and demand
Yeah,
thing.
exactly.
If there's no demand for it, or people are afraid to ask for what they need, then people who are not providing it are going to think they can
They really
not
don't need
provide
it. Yeah, exactly, exactly. Yeah, and I think that a big part of that is people being empowered to know what they need and to ask for it and to begin to demand it and to advocate on their own behalf and things like that.
What they need, to know what they need, and that they have a right to ask
To
for
ask
it.
for it.
That's the big one that
Well,
I
I
run
think
into
that's
the
the
most.
hard
is
one
that
with mental
people-
health is because we kind of don't even want to ask to begin with,
Right.
because we feel like, I have this problem and I should be able to handle it on my own, but I'm not. I mean, all of that self-stigma kind of feeds into that. And then to sort of have that system that is sort of putting up barriers on top of it,
Right.
it's the perfect storm.
Absolutely. And
know?
that's just, unfortunately, that's one of the best ways to deter a person from asking what they need.
Right.
Is just to make it slightly more difficult than
Harder.
anything else.
Yeah, that's so true, and it's unfortunate because we do sort of have now at least some laws in place that are working
Right.
towards making these benefits more protective for people.
And there are people out there who are now, people who are out there, finding them, get online,
Right,
go looking for people willing to fight the good fight to help them out.
Yeah, and I think the whole idea of the workforce education and training through the Mental Health Services Act
Right.
could also be helpful in terms of, I know they're providing some educational loans and things like that to get people into the mental health field, because I think we really have had a shortage of mental health
Absolutely.
workers, at least in the last decade or so. And so now that the need is there and people have the expanded coverage, we don't have anybody to take care of them. We don't have anybody that can provide these services. And so, and particularly I see that in the rural communities, much less so in a place like LA or Sacramento, but in some of the more rural communities.
Where it's harder to get to services.
Those people are still struggling to get even the most basic benefit.
Right.
They really still don't have that, I think we covered most of our questions. Is there anything that you kind of feel a pressing need to tell us a little bit more about, or?
Actually, I want to throw in a plug.
Yeah, please
So,
do.
in the appeal process, I know it's really hard. Appealing, it can be very stressful.
Well, people give up. It's one of those
They
things
give
that
up.
just.
They don't know what their rights are. They don't know what they can ask for. The daunting task of writing a letter to the insurance company
That's a
that
big deal
says,
for some people.
I can't. It's hard. Basic English sometimes is hard. I have a hard time with it sometimes. I wanted to put in a plug. Disability Rights California and the Parity Implementation Coalition have each written toolkits to help people do an appeal. We wrote one based on California law. The Parity Implementation Coalition wrote one based on federal law. And within that toolkit, within that booklet, is definition of what parity is, what the laws require. There is charts to help them keep track of their telephone calls when they're talking to their insurance
To
company.
journal everything and take down information.
Right. There's also sample letters that they can just
Perfect.
plug in their
Their
name,
name.
their
Yeah.
insurance number, and legal opinion letters to help support their position.
Great.
This is a residential treatment. You're required to provide that for me. That's because it's top of my head. And then here
Wonderful.
is a letter that says, this is how the law applies. This is the way it's supposed to apply. This is
It
what I
should
need
apply
you
to
to
me.
do.
Right.
And then those, you can send those to the insurance company. They also have contact information for the different regulating agencies.
So who
to help-
to send it to?
who to
Because all
apply
of that
through.
can take a month of Sundays just to figure out.
Actually, for both CDI and DMHC, it's really simple. If
Really?
you
Great.
if you don't want to deal with the form, if you don't want to try to type up something, it's a simple telephone call.
great.
And they have a staff.
So it
on
sounds
that.
like there is some public support for these laws
There
and to
is.
make sure that people's rights are being covered and that they're not being violated. It's just.
Right. It's just finding the resource and knowing that it's out there.
So where can we get the toolkit, Laura?
Okay, so Disability Rights California has a a parity webpage. I have, sorry, claimed ownership. We have a web page specifically for equal insurance. If you go onto our homepage, down towards the bottom it says equal insurance, and you can click on there. The toolkit is there. We've got a lot of...
So you can just download it all?
Oh yeah, we've got
great.
fact sheets.
Yeah, we need that to help folks when they come to us with these
I do
issues.
a tip of the month that's on there. There's a lot of information there. And then the Parity Implementation Coalition, if you type Google Federal Toolkit,
it'll pop up.
Federal Parity Toolkit, and it'll pop up. That's they've been really nice. I know Mental Health America has also got that one.
Yeah, our national or
the
our
national,
right,
the national.
right.
As a matter of fact, I think I got it off the national webpage.
Yes, I think our national office, because they've been very involved with passing parity on the federal level. Yeah.
Right.
So
the toolkits are there. There's some guidance, fact sheets.
Right.
There's
just to walk people through things and give them some resources and some guidance on how to manage these things.
Right. We're working on. We've gotten one mini video up now that talks about what the California parity law is and how it's supposed to help out.
Wonderful.
So there's those sites. I know that for MHAS, the Mental Health Advocacy Project and Mental Health Advocacy Services, they have links to materials also. So they're out there.
Right. So people just need to kind of know where to go. So it's very helpful to have you on the show today so that you can really educate people in the community about these really much needed services, and to know that they do have rights and that their mental health matters and that they can get access services, that there are parity laws that cover those things. And I think, knowledge is power in so many ways, and people need to know that they can ask for things.
Right.
They can say this, wait a minute, I'm supposed to be covered under parity, I should be able to get this.
Absolutely.
And not to be afraid of that,
Absolutely. And if there are any questions, if viewers have any questions or something like that, I'm here in Sacramento.
Yeah,
I'm very happy to answer questions.
So you folks are pretty accessible. Yeah.
I am very accessible. My
That's
agency
wonderful.
knows that this is what I'm doing and this is where I need to go.
Right.
So, you can call our office. If I can't find the answer, I will make sure I find someone who can.
Wonderful.
So we're there.
Yeah. No, I love that you guys are willing to do that because it's so important for people. And as we talked about a lot today, it can get kind of complicated.
It can be very complicated.
Do you think that the federal laws in some ways help strengthen the California law, or are they just very distinct in the way they're implemented?
I actually think the overlap of the two is probably the best.
Yeah, that's what I was thinking. I think it could be actually a really good thing, right?
It could be a very good thing.
Yeah.
I wish the rest of the country would do the same.
Right.
But the overlap, you get the trigger to ensure that people with mental health needs get something, because the California's got the mandate, which forces the federal law to go into it.
Yeah.
I'd like to see a more expansive law.
Right, in California.
California's got the limitations, but I'd like to see a more expansive law with both of them kind of overlapping a bit more, where you get better description and better guidance with the federal equality, the federal balancing, but making it as clear cut as this is who's covered and this is why.
Without a lot of the vagueness.
Without the vagueness.
It always opens a loophole, And it feels like government always tries to be vague in some way or another, probably in some way to protect the scarce resources that we have, but at the same time, these are really important laws,
They
and
are.
long overdue.
Absolutely. My concern is that, unless it's purchased in California and it's triggered by something here, those people whose plans are purchased outside of California are not going to be getting the same benefits.
The same kind of benefit, exactly.
They don't get them.
Yeah, that's really interesting. And in some cases, it seems like it could be less.
It could be a lot less. I know that Alaska has no parity law.
Wow. It just always amazes me in this day and age that we still don't see mental health in the elevated role that it really should be in terms of a public health need, I think our physical always seems to sort of take precedence, but as we well know, if your mental health isn't in a good state,
Right.
it really affects all of our other health, all the other physical parts of our lives.
I'm not even sure where I've got the quote, but it's now on my posters and everything like that. There's no health without mental health.
Yeah, I love
That's
it. I love it. That's one of my favorite as well. And I don't know who came up
I don't
with
know where it came from. I've got it somewhere.
Yeah. Well, thank you so much for being on the show
thank you
today,
so
Laura.
much.
It's a big help to us, and I know to people in the community that are still kind of confused about these kind of things.
Right.
So I'm sure we'll be in touch for more information in the future. But good luck with everything, and thank you so much for being here today.
Thank you so much.
And thank you for tuning in. And please remember that your mental health matters.
When I think of where I've been, the good times and the bad, on a scale of 1 to 10, either way I'm glad, 'cause I'm not alone. As I'm reaching for the phone, your voice is there, you really care, you're my comfort zone. Sometimes when I'm lost, crushed beneath the pain, though I can't afford the cost, I just smile and play the game. But there's a healing place where I cannot pretend. Your smiling face, your heart's embrace heals me again. So even when the storm is strong and I'm deaf to my own cry, I faintly hear a distant song and I simply can't deny that I'm not alone. 10,000 times I've known my best bet is that first step for hope. Trying to stand tall, I'm haunted by the past. With my back against that wall, one thing is clear at last. The kind of love you show to me flows from an endless stream, with shores so wide it won't subside. My mind had never dreamed how I'm not alone. Even when I'm on my own, your gentle touch is much too much to let me roll. So even when the storm is strong and I'm deaf to my own cry, I faintly hear a distant song and I simply can't deny how I'm not alone. 10,000 times I've known my best bet is that first step.